Hello, this is Jason Goodwin. I'm here to talk to you a little bit about fourth semester nursing, leadership, chapter 22, quality improvement and patient safety. Really excited to talk. So talking a little bit about quality improvement and safety. So there's an urgent case for quality improvement, or there has been over a period of time in our nation's healthcare systems since before the Institute of Medicine's report on the amount of harm caused by hospital errors. That was around the year 2000. So since then, the Institute of Medicine has started implementing the 6 aims to guide improvements. They call it STEEP. So this is a mnemonic to remember what we're trying to do. We're trying to provide safe and timely care, effective and efficient, equitable and patient-centered. The next step on the IOM's 10 simple rules, they have 10 simple rules to guide improvements. So care based on continuous healing relationships, care customized to patient's needs and values. The patient is the source of control. Knowledge is shared and the information flows freely. Decision making is evidence-based. Safety is a system priority. Transparency is necessary. Needs are anticipated. Waste is continually decreased. And cooperation among clinicians is a priority. Now, one of the things that you'll see, I'm sure, in here numerous times is the cooperation between clinicians includes a lot of need for communication, right? So that's a commonality that we struggle with and we continue to try to improve all the time. Okay, the cornerstones of quality management. So quality as it's defined comes from the customer, right? And so the reason that's important to note is because, for instance, we may look at the quality of care in the United States and say, well, you know, we have great quality of care. We have all the bells and whistles that we would want. And then some people from other countries might say, yeah, you have all the bells and whistles, but what is the associated mortality and quality measures that you get versus another country that's spending less per citizen, per gross domestic product. So, you know, it's one of those things where you have to think about what is the client, how are they defining quality? So quality by American consumers is often, can I get in easily? Do I understand what's happening to me? Is it successful? As a surgeon, for instance, you might say, well, a successful surgery is saving your life. We did have that little issue of the infection afterwards, but you know we succeeded with our goal. Well, the patient may not have that opinion. They had to go through that infection, and you know that might have affected their view of the whole thing, right? So the other ideas are the scientific approach. So we want support for all of our employees to develop knowledge and skills, and that's going to take training and development related to quality improvement. Quality improvement is it's a way of being, and so over time you start to live that lifestyle of what you when you see it, improve it, and when you have your entire team trained up to that, you get some pretty good results. And like I was saying, all one team, the belief in that the people who are working hard to serve the customer, and that there's that unity of mission. That's something I've never really run into that isn't at least obvious in the unit, that we all have that mission. Regulatory and accredited agencies. So regulatory and accreditation, those are either government organizations or non-government organizations that are quality-based and research-based organizations. So examples of that would be a regulatory agency would be the California Department of Health, CDPH, the Center for Medicaid and Medicare Services, If you're in like UC Davis, you might have the OIG, the Officer Inspector General. So those are all things that might be considered regulatory. And some of them are blurry, right? Like the CMS, they have accreditation. They have the federal guidelines, right? And Title 22 and all that kind of stuff that you have to be careful of. Actually, that's California. But anyway, but they actually drive a lot of the regulatory and accreditory requirements. So you'll see Joint Commission, you'll see AAAHC, which is a sort of a Joint Commission that's more related to outpatient therapies, and other organizations that will come in and they will inspect the hospital. The hospital actually requests that and pays them to do that. The reason for that, and they're not government, Joint Commission isn't, but the reason they do that is because that certification that keeps them in good standing with places like CMS and things like that. And in some cases, the Joint Commission can actually, it's called deemed status, they can actually come in and do both the CMS and Joint Commission inspection at the same time. So there's a lot of ways that those things blend over. So the state licensing authorities, they'll often require things like quality management activities, and they set quality standards. An example of that is what you might hear called a never event, right? And so examples of these are things that should never happen in the hospital. So a central line, hospital-acquired central line infection, or a retained surgical item, medication error resulting in death, a fall. Those are all things that the state requires us to monitor. And then there's also often reporting requirements if the patient has been permanently injured. And there's a time frame around it. So in California, they can be pretty picky. Okay, so we talked a little bit about Joint Commission. They voluntarily seek accreditation for that gold seal of approval in quality and safety standards. This is done throughout the world. Joint Commission certifies hospitals in other countries as well. And there are actually people that go out to other countries and help stand up hospitals under the Joint Commission recommendations, and they get paid pretty handsomely to do it. Joint Commission was one of the first agencies to really drive this sort of change and embrace the QI principles, quality improvement. And we'll talk a little bit about some of the other groups as well. So the Joint Commission also requires, and as do all regulatory bodies, they require certain things to be monitored. And so that gets into why we capture things like metrics or standardized quality measures, right? Many of you have heard of the core measures or the national patient safety goals, things like that. Okay, so the National Hospital Quality Measures. These measures are being used along with patient satisfaction scores or other clinical measures. This is part of the pay for performance aspect that started a couple years ago with the American Affordable Care Act. So the goal is to move healthcare payments away from just paying for the service to paying for quality, right? And so quality and or mishaps. And so if you have a group of 10 hospitals and there are 2 that are performing far above the norm, those 2 hospitals may end up getting paid in certain circumstances another 5% than some of the ones in the middle of the pack. And then some of maybe the lowest 2 on the same measures would get paid 5% less than the rest of the pack. So there's a lot of financial stakeholders that are trying to do the best they can for many different reasons, which is good because that's what creates the incentive to improve care. Mandatory measures in this include things like addressing acute MI, heart failure, pneumonia, perinatal care, And the Surgical Care Improvement Project, which used to be called SCIP, now it's just called the Surgical Improvement Project, and it has to do with some of the quality measures intraoperatively and then postoperatively. There are other measures including children's asthma care, stroke, immunizations, hospital outpatient departments, and hospice-patient psychiatric services. Okay, so a quick critical thinking question. A patient understands that the hospital where he is currently having the procedure done is Joint Commission accredited. The patient asks the nurse how accreditation ensures the patients receive the best care possible. The nurse informs the patient there are several quality initiatives required by the Joint Commission in order for the hospital to be accredited. One of these quality initiatives is known as, let's see, so we have Pareto charts, never events, National Hospital Quality Measures, or the PDSA cycle. So the correct answer is C, because the Joint Commission initiated performance measurement and improvement, and they started this known as the National Hospital Quality Measures. It's intended to support organizations in their efforts and supplement their accreditation process and quality improvement efforts. So the other answers, A, Pareto chart it's a bar graph with the height of the bars reflecting the frequency. I'll show you a picture of it in a few minutes. It's helpful in identifying a process problem, but not specifically related to this. The never event, although it's definitely initiated by regulatory bodies. It was originally initiated by the Center for Medicare and Medicaid, CMS, and it's a way to track serious adverse events. But this was not initiated by the Joint Commission. It's not directly part of accreditation. It is the reporting of adverse outcomes. And then D, the PDSA cycle, again, we'll talk about this. That's a cycle of improvement that takes you through the plan, do, study, act cycle when putting in small tests of change for quality improvements. Okay, so the foundation for quality monitoring and evaluation. These are clinical indicators. Wherever you work, you'll see these things, clinical indicators. Essentially what they are is metrics that, as professionals, we measure in our sub-area of care. We all know that if you work in the ICU, you have a specific knowledge set. If you work in the neonatal unit, you have another. If you work in surgery, you have another. So not everybody knows, everything, and even a person floating over, there are very specific indicators that each area uses. So because they're experts and because they know what quality looks like in their departments, they may be running these tests or initiatives as you are around, so you can keep your eye out for it. So what it does is it measures certain aspects of care that, as experts, they recognize show the degree of quality. So, the proficiency in which the care was carried out. An example of that is administering the correct IV solution at the prescribed rate. Okay, right? Another example would be how quickly they get a post-operative ventilator patient off the vent, right? Or maybe a post-operative Foley catheter. It's used as an assessment of clinical care. So it gives you a snapshot of a measure that corroborates the idea that the quality is being upheld. Process improvement. So there's a lot of different types. I love process improvement. I actually went to a 7-day course from the Institute of Healthcare Improvement, and it was called the Patient Safety Executive Course. Great course. They taught us all about all the different types of performance improvement. Lean methodology is a method that was initiated originally by what they call high reliability organizations, right? And one of the first was Toyota. And they came up with this methodology. There's a book out there called, I think it's called The Toyota Way. And it talks about this methodology of studying the frontline work, understanding how to remove waste and defects from the systems. It's a systems approach that talks about how to remove error and obstacles from the workflow. Six Sigma is a variation of this methodology. Lean is like it's a huge movement. It's a little bit older now, but a lot of people still believe big in it, as I'm one of them. The Six Sigma aspect of the lean methodology is more of a technical aspect of this. When lean was in the manufacturing areas, and it started out in the military, in nuclear facilitation, the airlines, and Toyota. And so these organizations, they started doing some of these methods. And in making cars, you can get the number of defects measured down to, every single defect. When you're dealing with care, it's a little bit harder because there's patients involved. But when you're making widgets, you can actually determine how many defects are in the last million steps of your process, right? So the idea of Six Sigma is that you can get to a number to where the error rate is so low that it's considered in statistics to be a Six Sigma. It's the sixth standard deviation of error, which means it's like 1 in a million. So that's sort of the flagpole, right? Everybody wants to get to this point, but it's not really applicable directly for healthcare. Most people will just stay away from the idea of Six Sigma and just use lean. A failure mode effects analysis, also called an FEMA, is at the end of the year, for instance, you may do an annual plan to where you find something that is a problem and you're going to commit to it the next year, right? So an example of that would be we had a lot of sharps injuries last year. So this year, we're going to call that out. We're going to design a plan for the next year to identify what those things are, and we're going to improve them over time. And all of these above, they all support the key ideas of analyzing and understanding the work process. They call that in lean, they call that Gemba, go see the work. It's a Japanese term, go see the work. Selecting key aspects of the process to improve. So getting into the workflow and going into some tools, so we'll talk about that in a moment, to understand every aspect of what's happening and how things are being how errors are being introduced. Establishing a trial so that we can guide improvement, because as Mr. Deming, the father of performance improvement, said, nothing that, what did he say? What gets measured gets improved, right? So there's collecting and plotting data, because as I said, you have to monitor it to know where you are and make improvements. You have to interpret the results and analyze that, and then implement those improvement actions and evaluating effectiveness. The issue with this is that you have a group of people that are, now you're a change agent once you do all that work, right? So it's not easy work. It's very exciting though. Okay, so here's a process improvement tool for you. So this is a flow chart, right? This can be used to examine a workflow. And so for this flow chart, a physician writes an order for an IV solution. And then once it goes to the clinician unit, the unit secretary transmits that order to pharmacy. Pharmacy technician prepares the solution. The pharmacist validates. The messenger services delivers the solution to the nursing unit, and so on and so forth. So as you study this workflow, you'll start to understand where some of the problems have occurred. One of the interesting ways to do that is by asking the question why several times. So someone might say, well, we keep getting the person, we keep having problems getting our vancomycin. Okay, well, why? Well, it's not there when we need it. It takes too long. Okay, why? Well, the delivery system went down, and so now we have students taking it up. And okay, well, why? Why is it still not there, even if students are taking it? Well, we only have students 4 days a week, and once a week, it's it's a problem. So by asking that why several times, you get down to what's more of an underlying core driver of the problem, right? And so now you finally get to the point where you say, okay, well, if the only problem that we have is that, and at least until the delivery system is fixed, is that we don't have students 5 days a week to deliver these meds, and so that's why we have a problem. So that's a semi-easy solution to address, right? Once you identify where the problem is coming from. Okay, more process improvement tools. So this is a Pareto chart, and you can see this explained in your text, but essentially what happens is you come up with a list of reasons and you collect that data, right? It's just like any other data you've ever collected, right? How many people have blue M&Ms versus red M&Ms? But what you're doing is you are starting to tick boxes based on where problems occur so that you can identify the biggest bang for your buck. This is called a cause and effect diagram, often also referred to as a fishbone diagram. The reason it's called a fishbone diagram is because it kind of looks like a fish, particularly when there are more of these, right? So what you can do when you're doing this is you can see the cause and effect. So IV solution names misspelled in order entry, new labeling system installed, volume of orders increasing, high volume of pharmacy technician turnover. Okay, so you see all these and you go, okay, yeah, I see that there's some potential for error there. And then what happens is the mislabeled IV solutions. Now, you know you have a problem, but you also know that you have 4 obstacles that are getting in the way. So you can take these and break them down individually and develop processes to fix those. Okay, a run chart. So this is often helpful for identifying a smaller amount of improvements you want to make. So if I want to know where the problems are with my narcotic administration, I would need a Pareto chart to decide how many things, or even a fishbone diagram. But if I just want to know how many narcotics, what percentage of narcotics are scanned in my unit versus non-scanned, I would use a run chart to keep track of that one issue, right? And this is very helpful for performance improvement, just monitoring one initiative at a time. And so hopefully what you can do is over time you can substantially reduce and show improvement based on the data. Now, a couple things to know about this data when you're looking at it is that you always want to, and I don't want to go too far into this, but control charts are helpful to give you upper and lower limits, because what you want to be able to do is to see if it's statistically significant. And what I'll tell you about that is it's never going to be statistically significant unless you have at least 6 data points, and maybe more depending on the amount of things that you're testing. And also you want to have a number of, when you have a control line up here, and then you have one down here, and you have a number of dots that are up above that control line, you know that there's been what they call a system cause variation, which means you've made a change. So it's a little bit more complicated than we're going to talk about here, but it's pretty interesting once you get into it. Okay, so critical thinking. So quality improvement team was conducting data to determine how nurses use their time and to identify areas to improve efficiency. The team found that 60% of the nurses' time was spent charting, 30% was spent in direct patient care, and 10% was spent on patient and family teaching. What type of chart would best support the data collected by the quality improvement team? Would it be a cause and effect, a flow chart, a Pareto, or a time plot? So the Pareto is correct because it's a graphic tool that helps break a big problem down into separate parts and separate contributors. And so that helps identify which problems are important or most common. Okay. The cause and effect chart lists all potential causes of a problem arranged by categories, and the flow chart provides pictures of the sequence of steps in a process, but doesn't identify the causes of the problem. D is incorrect because the time plot graphs data points as they occur over time. It doesn't identify the major causes of the variation. Okay. So the Pareto chart helps you understand the causes of the variation and what level of occurrence you have there. Okay, so standardizing care processes. So you might hear this called out as best practices, clinical guidelines. It's care that is intended to be carried out in a uniform way, right? So the only way that we're going to improve quality comes from reduced variation, right? Variation meaning different ways of doing the same work. We want to standardize the work that we do, standardize the expected care, and ideally the outcome, so that we can improve that care in the care of our patients. Employees are trained to perform procedures according to standards rather than by learning and watching others and their own nuances. So one of the things that's important about this is you have to be careful when you institute a standardized procedure. You have to make sure that the education is done and is committed to on the outset so that people don't get lost in what is being expected. Oftentimes it's important to install that in your onboarding process. And of course, all stakeholders, including other departments and physicians, should be considered when communicating it. And once you do this, you want to be able to create a shared understanding that changes to this aren't made haphazardly, right? They're made very consciously and selectively so that everyone is rowing in the same direction. Okay, so the Institute for Healthcare Improvement, I told you that I spent a little time with them in Boston. It's a voluntary organization formed to assist healthcare leaders to improve quality. They've led developmental change of concepts in reducing patient delays, cesarean deliveries, adverse drug events, and they've been monumental in surgical care as well, leading some of the changes. So here's the plan, do, check, act, PDCA, PDSA, study, act. They're variations of the same idea. But essentially, you decide that you want to make a change, and you study the changes. And what you do is you start to ask yourself, how will we know that this change is an improvement, right? So how will we know? Well, if I start trying to improve narcotic administration, probably pain scores will go down overall. So I could study that. I could study the amount of scanning just as a matter of process. Are we doing that correctly, and could that be correlated with errors if we're not? And then what changes can we make as a result of this improvement? What opportunities does it give us? So what you do is you plan first, and you develop an action plan based on 3 questions above, and then you do the do is taking actions to test the plan, right? So you want to come up with a plan, and you want to take actions and plan what you're actually going to do. And a lot of times this is helpful to do to build some SMART goals, so that you can start to lay out what are the important things to facilitate. So after you do, you take actions to test this plan, you check it, you go back and you say, okay, we planned it, we did it, and we started to implement, and we went back and checked and said, okay, is this the way we need it to be, or do we need to make little tweaks? After we've determined that those are all where we want them, then we can act, and we can implement those changes in a real work setting based on some testing. Quality improvement model, we want to ask 3 fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? Patient safety. Institute for Safe Medication Practices, ISMP. That's one of the organizations that helps improve medication administration practices. So they're nonprofit. They started as an education resource to prevent medication errors. They review all sorts of services, including expert review of reported errors. Healthcare professionals across the nation voluntarily and confidentially report these medication errors and hazardous conditions. And they offer medication safety self-assessments in order to verify your processes and identify if there are problems. Programs initiated to improve patient safety. So the Joint Commission initiated the Sentinel Event Standard. So organizations are required to carry out steps and root cause analysis to fully understand the factors and systems associated with adverse events. The root cause analysis is when a hospital will take an event and break it down to its bare parts and understand where the errors were so that it can be a learned understanding moving forward to prevent it. And then the Joint Commission also put in the National Patient Safety Goals, and there's a box in your book about that for the 2018. But if you want to look up the 2021, they put new ones out every year. The CMS, as we talked about before, has never events. So never events are serious, costly errors that should never happen, and that CMS will no longer pay for the additional cost of hospitalization to treat. So whatever extra hospitalization you have because of that error is going to be on the hospital, and CMS, they determine whether those things have occurred. And then the other organization that I talked about, I actually do surveys for them. It's called the AAAHC. They do healthcare accreditation for outpatient surgery centers and some of the other areas. Professional nurse and patient safety. So answers for improved patient safety require all of us to pull together and review our critical learnings all the time. Our challenge is to make patient safety a personal priority. That's my personal commitment to my profession, is to be safe. 2 nursing functions closely influence patient safety: monitoring for early recognition of adverse events and initiating deployment of appropriate care providers to intervene when these situations occur, right? So understanding what it looks like to recognize problems and having a fast response to implement change when those things become a problem. Quality and safety in education and nursing. So the QSEN project was created to support development of 6 competencies for nursing students. You can look this up if you want. There's 6 competencies. It's patient-centered care, quality improvement, teamwork and collaboration, evidence-based practice, safety, and informatics. Continual improvement within these competencies allows nurses to shape the quality and safety of healthcare systems and guides nursing education to help make that happen. Our role in quality improvement, we enter our practice with the knowledge and skills to make quality improvement part of our regular work. You are on the senior end of training for your colleagues in profession, right? So you have your colleagues as physicians, but as a professional nurse, you have a responsibility and will be called upon to do some of this analysis and to, on the front lines, prevent those challenges on an ongoing basis. It shouldn't be considered a separate function from your role. It should be something that's embedded in your view of your clinical environment, and over time, you will start to feel very comfortable with how to address those. I suggest as students that you start to implement those now. The best ways to do that is to be proactive with your own practice, and if you run into problems, don't cover them up. Pull them out, address them, and you'll be better for them in the end. And by the way, you're not going to be it's not going to be the end of the world if you make a mistake. You just have to call it out and fix it. Okay, so that's all for us right now. Hope you enjoyed it, and we'll talk soon.